Hi, welcome to the module on children with autism. My name is Karola Dillenburger. I'm really pleased to see you here. I'm going to try and see if I can do this lecture and record this lecture for you, given the circumstances at the moment. So let me just see if we can share screens. I hope we're sharing screens now. Let me see. Share this screen. Yeah. So what I'm going to do is I'm going to have a quick look at autism for you, about what is autism, just as an introductory lecture. Autism is diagnosed on with either of two different diagnostic manuals. It's the DSM-5, the fifth version since 2013, or the ICD, the International Classification of Diseases. The Diagnostic Statistical Manual is mostly used in America, but most of the literature that you'll be reading is probably using that as a diagnostic manual. In Europe, the International Classification, the ICD-11, is mostly used, but they're very, very similar these days. Now that the ICD-10 and the DSM-4, there was more difference when it comes to autism, but now they are much more similar. In the autism spectrum disorder in the DSM-5 is diagnosed when there are persistent social communication and interaction issues and restricted repetitive patterns of behavior, interests or activities. And at least two have to be observed for a prolonged period of time, and they need to include some sensory issues. Now, the very interesting point, these are the two behavioral measures that underpin the diagnosis of autism. So people have to behave in these ways, be directly observed or observed by caregivers to behave in these ways to get a diagnosis of autism. But what's very interesting is that there are actually three levels of support needs. The first level is that they need to require some sort of level of support for diagnosis. So I suppose in some sense you could say that people that don't have any need for support would not be diagnosed. Or else in level 2 they require substantial support, or they require very substantial support. Interestingly, there are no medical tests at this moment in time. There's a lot of discussion about genetics. There's a lot of discussion about different brain functioning. But at this moment in time, when we're talking here in 2020, there are no medical tests for autism. It is all based on purely behavioral observations, direct observations, or observations of caregivers. Now, the rate of the prevalence of autism has risen very substantially over the last while. In children nowadays, a conservative estimate would be 2% of children, which, when you think of the American population of 74 million children, that would be 1.5 million children. In the UK, it's nearly 250,000 children. In adults, the acknowledged prevalence rate is about 1%, but both of these percentages, we'll come to that in a minute, are probably vast underestimations. That means 3.3 million Americans and 2/3 of a million of UK in the UK population would be likely to have been considered to be on the autism spectrum. Now you can see there on the right graph that the percentages or the number of people diagnosed with autism varies very, very much. In the United States, Japan, Canada, the numbers are very high. United Kingdom, Ireland, Denmark, United Kingdom and Ireland, they're very similar, and they've become fewer and fewer. Now, this is probably because of a number of reasons. It's very unlikely that the actual prevalence is so different according to different countries. It's much more likely that the diagnostic criteria are applied, and also the number of diagnoses that are available and that are being made are very different per country. In Northern Ireland, the most recent findings are that 4.2% of school children in Northern Ireland have a diagnosis of autism. The prevalence rate in females is much lower than that in males, with 2% versus 3.4%, 6.4%, sorry. And the percentage, the proportion of the children with autism who have no special educational needs is only 14%. That means that 86% of the children with autism also have special needs. The prevalence of autism was 37% higher in the most deprived centile of the compared to the Northern Irish average. So that means that many more children with autism live actually in deprived circumstances. If you want to see those figures more clearly and in more detail, there's a URL for you to look at it. Here you see the graph of the prevalence rates as it has grown over the last few years. So basically, it's grown about 0.2% every single year, with more percentage growth in the last few years. But I think there was a change in the way they were counted. So the number of children with autism has risen dramatically. And in terms of special educational needs, as you can see there, the SEN stage 5 is the highest level of support needs, and 2/3 of the children with autism require that level of support needs. So in the context of disability rights, the question arises, is autism a disability? Is a disability not a disorder or disease? A lot of people within the disability rights movement, and I suppose in some sense we want to count ourselves in that, promoting disability rights, the term autism spectrum disorder sticks in their throats. They don't like it. They don't like this idea that autism is a disorder or a disease. The kind of language used is very, very important, and in our case it comes from the DSM-5 and the ICD 11, but even previous ones had the same terminology, that are psychiatric disorder. They're medically based on the medical model. There's an autism self-advocacy movement that call themselves autistic and proud, a powerful lobby for governments and policymakers. These are autistic adults with autism who actually like to be called autistic adults rather than adults with autism. There's another debate to be had around what is the best terminology. Research has shown that professionals tend to prefer the person-first language, so that would be an adult or a child with autism, or better still, a child with a diagnosis of autism, which describes very clearly this child has a diagnosis of autism, whereas self-advocates quite often prefer the language of the autistic child. Now, a lot of the self-advocates are obviously adults, so it's going to be difficult to decipher which language to use and which terminology to use. Some people would say that it is most respectful to use a terminology preferred by the person that you're talking to. So if you're talking to an adult who says they would like to be called autistic adult, then you talk to them in that language. But ultimately, it is a question of your own preference and attitudes. As a professional, I would advise you to use a person first. So people are people first, and the disability is part of that, being that person, but it is not what defines that person. The person is a person first. In the disability rights, there's a focus on the autism rights and on the autistic culture. There's a neurodiversity movement, which is very, very interesting, and you should probably look it up and read around it. That views autism as a natural variation in the human brain. It is basically saying that autism is a diversity, it's a neurological diversity, and it's to be celebrated. Now, the important point is really acceptance, that there might be need to adjust the environment. There might be need for like a quiet shopping time and cinema shows and so forth. The other question that is really important to consider is autism lifelong? We hear very many definitions of autism as a lifelong developmental disorder. I would caution the term lifelong, and I would like you to think about that term very, very carefully, because there are many other diagnoses that are not termed lifelong. There's no lifelong Down syndrome, there's no lifelong depression, there's no lifelong anxiety disorder, there's no lifelong ADHD. Why are they not called lifelong? Why is autism lifelong? Is that a good idea? Now, the reason why autism was considered, why the term came along, was that it wanted to make sure that it wanted to make clear that autism is not just happening for children. I think it came at the time when autism was very much considered a child diagnosis, a diagnosis that is just affecting children. And then the realization came to be that adults have autism as well. And then we said, well, they started using the term lifelong to identify that adults also have autism. Now, what happens with interventions, with helping people with autism, without ABA-based early interventions, here's a results from a study of 60 children with autism who attended specialist autism schools when they were young. They did not have any specific ABA-based early interventions, no intensive intervention. They just attended these autism schools. At the 40-year follow-up, the results were in Howland published the 30-year follow-up and the 40-year follow-up, 2004 and 2014. 45 of these 60 participants, so 75%, had the same IQ with some improvement in language. But 25% could not be assessed because they had not developed language above the 3-year-old level, and they had severe challenging or self-interest behaviours. So here we have the population who, while they attended in specialist autism school, and you're talking about 50, 60 years ago, at least 50 years ago, if not longer, that they attended these schools. But with no specific intervention in those days, the likelihood of them actually developing language and developing their EQ, improving on their EQs, or even working on challenging behaviours and self-interest behaviours, was not given. There's 25% of these participants could not actually be assessed at all because of those problems. So in contrast then with ABA-based early interventions, which have been around for a long time now, the 25% optimal outcome participants no longer met the autism diagnostic criteria in the fine adult study, and significantly more of these children had received ABA-based intervention, particularly between 2.5 and 3.5 years of age. So there's a clear evidence that these children, especially the ones that had ABA-based interventions very early and intensively, actually moved off the autism spectrum diagnostic criteria that I've just alluded to. So the idea of is autism lifelong is actually becomes really interesting, because do those people still have autism when they no longer meet the diagnostic criteria? Some would say they'll always have autism. You can't take away the autism. But on the other hand, when you realistically look at it, the autism was only diagnosed on the basis of the diagnostic criteria. And if they don't meet them anymore, should they still have a diagnosis of autism? This is a question I think that we need to think about very, very carefully, because it has very important implications. And one of the implications is that if autism is lifelong, people tend to not want to diagnose very young children, because they don't want to put this label on a very young child in case they grow out of it, right? So there's an acknowledgement that a child that has it, that would merit a diagnosis of autism because they have been assessed, and people would discuss about, well, should they have a diagnosis with autism? They clearly have they clearly meet the criteria, but let's wait a little while in case they grow out of it. So there is an actual acknowledgement that autism diagnostic criteria, that behaviours can change, that children who once meet the criteria maybe at some point no longer meet them, and therefore quite often people don't want to give it an early diagnosis, which is a problem because, as you can see here from the Ornstein study, very clearly, the earlier the intervention, the better. So another study, the more historical study, was 47%, so nearly half of the children. It was a very small study with only 18 children involved. But half of those children were indistinguishable from typically developing peers after early intensive interventions. Indistinguishable, not meaning they were the same, or they were normal in a normative sense. They were indistinguishable from a typically developing peers. And if you have a group of typically developing peers, of course they're all very different. Of course each of them is an individual. Of course each of them has their own little idiosyncrasies and hobbies and interests and whatever else. But what is meant here is not that they were the same as the typically developing peers. They were not. If you had seen a group of 5 youngsters walking about the place playing together, you would have not been able to say which of these children had a diagnosis with autism when they were very, very young. That's what means. What's meant here by indistinguishable. It does not mean exactly the same, because no kids are exactly the same. Further study here is where 18% of the children diagnosed at age 2 years old received mostly behavioural intervention, lost that diagnosis by the age of 4 years of age. So what is actually offered, generally speaking, in autism interventions to these children? Well, for the most part, in the UK and in Northern Ireland in particular, the eclectic approach is used. But people are saying the eclectic approach is the best and we want to do a bit of everything. But when I looked at the definition of eclectic approach, it's actually impossible to see a clear definition. The definition that I found was an assortment of educational and therapeutic techniques that is as varied as the school districts from which they come. In the Oxford Dictionary, eclectic is defined as deriving ideas, styles and tastes from a broad range and diverse range of sources. So it's a bit of everything is really what an eclectic approach is. So there are lots of approaches to autism. There's teach, there's sensory integration, there's PECS, there's floor time, there's special education, there's sunrise, there are lots of other manualized programs, and there's like a Hanen program. And so the eclectic approach is causing, it's a little bit of everything, and you just sort of take what you can and give it to the child. Now there are a lot of problems with this, because for instance, staff training in all intervention methods is impossible. So when you call it eclectic, it never is truly eclectic, because nobody is trained in all of those. And of course, these are not all of them either. The fact that I've just said the other manualized programs, I could draw as many boxes there again and again and again, but it is impossible that staff are trained in all the intervention methods, so it's impossible that staff can select clearly from them all, right? So the decision-making about what to include and what to exclude is based on a range of things, including staff training, okay? So it's not a free choice of everything. Another problem is that what is the theoretical knowledge base? And are there conflicting theories involved here? Which is quite possible, because you might have one approach that takes a very non-directive approach, another takes a more adult-led approach. They could be conflicting, and the child could get something in the morning which is very non-directive, and they're directed by the child more than by the adult, and that could be contradicted in the afternoon by the more adult directed intervention, or vice versa. The other thing is that a lot of these different interventions don't have an evidence base. So some of them might be evidence-based, others not. So which ones are you using? Do you know the evidence? Do you have an actual, have you done the research to know what evidence base you're actually applying here? And of course, how do you measure the synergetic, the combined effect? Could the intervention effect cancel each other out? How do you measure the combined effect of those two interventions? Because of course, if you're doing something to a child with an intervention, it's not going to be the same child that you're working with. The child will have changed, the behaviours will have changed, and the synergetic effect of these different interventions, you don't know. So what's interesting is that in the eclectic approach, some people even add ABA into that and sort of say, oh no, we're doing a wee bit of ABA in our school, and we're doing all of these other things, and we do a little bit of ABA. Now, I want to come to the point where this really does not make sense. It's a bit like science for sale. There's ABA, there's PBS, there's verbal behavior, there's LOVAS. Which one are we going to buy? this does not make sense. Now, what I want you to watch, the ones you would have had access to Simple Steps. I would show you the functional assessment video of Simple Steps here. So please remind yourself if you have you've watched it a while back in the module, or if you haven't watched it yet, you will. I'm not going to show it to you now because you maybe just take a break here and come back to this lecture once you've seen it. So what is applied behavior analysis for autism? The behavior analysis is a science that stems, there has three different brands to it. There's a philosophy of science underpinning it. There's experimental analysis of the science, much as any other science has a laboratory aspect to it, where the basic principles are explored. And then it has the applied science, which is ABA, applied behavior analysis. Okay, you have a wide amount of knowledge. You have very clearly stated ethics, so all known behavioral principles, individually tailored functional assessment, functional analysis, and database decision making is the fundamentals of ABA. And now ABA can be used in a range of different fields, autism being just one of them. So you can use applied behavior analysis. You can apply it to any field where human behavior is being the question. So if you're working in autism, you need to have autism knowledge. There are ABA autism guidelines. There's knowledge to be had around autism. And then from there, you develop different interventions for autism. There's natural environment training. There's discrete trial training. There's stimulus control procedures, like PECs, for instance, like picture exchange procedures. There are shaping and chaining, very basic behavioral principles. There's verbal behavior systems, where your focus is on verbal and communication behaviors. There's pivotal response training, where your focus is on pivotal responses. There's early intensive behavioral interventions. Most of that is where the discrete trial training happens, and also natural environment happens. A lot of different approaches, a lot of different technologies are used in the very early intensive, but that's mostly where the discrete trials happening. Incidental teaching might also happen in the early intensive intervention, where you use every incident that comes across. You might create some incidences so that you could give some teaching opportunities, or you might just use an opportunity, an incidental teaching moment. So every moment in the child's life becomes a potential teachable moment. Precision teaching, where the important point is around fluency, accuracy, and speed of the behavior. And of course, a lot of other individually tailored procedures that you might want to use. So that is the building blocks for applied behavior analysis in the field of autism. If you applied it for other fields, we could obviously start with a building block at the bottom and build up further systems on top of that. This is a face that most of you probably are familiar with. This is Temple Granton. And she said, when I was very young, applied behavior analysis methods were used to teach me to talk, and lots of praise was used. This was required to get my speech started. So she is very clear that some of them they might not have been called applied ABA methods at the time, because the terminology is sharpened up a little, but definitely behavioral methods were used to help her to speak. And she's now a professor at the university, a public speaker, and very well known everywhere in the world. I'm going to give you this link on the webpage. This is a mother talking about her experience with ABA, and I'm going to put that link up for you to watch her separately from this lecture. So you might want to pause the lecture here and watch her. And then I want to just show you a list of evidence base using the science of applied behavior analysis. This is an evidence base of publications. So as you can see there, each of these publications, I'm going to scroll through this, and you'll be able to pause the video at various points to look at the literature. At first, the independent panels and reviews. There were lots of them, very many over the years. There were lots of meta-analysis of applied behavior analysis research, and there were peer-reviewed articles by behavior analysts. And there were long-term outcome evaluation of the UCLA Young Autism Project, That was Lova's project. That was from the 60s and 70s. There were long-term outcome evaluations. Sometimes people say, oh, the interventions did not actually last, the gains did not last. Well, here's the outcome evaluations. The group outcome and long-term replications of applied behavior analysis intervention with autism. There are quite a lot of them. There are comparison data, long-term outcome of autism without ABA treatments, and research on cost effectiveness of early intensive interventions. Applied behavior analysis of autism in the beginning, so we're talking the historical papers from the 60s. There were some papers in the 60s. There were a number of papers in the 1970s. So feel free to, at any point, you can stop this video and you can look at the references. I'm slowly scrolling through them so that none of this goes missing to you. In the 1980s, there were more papers published in applied behavior analysis. In the 1990s, more papers. Of course, you can see in the 2000s, these are now becoming selective publications because there were becoming so many that for the last 20 years, the publication rate has just gone crazy. It's just so much. So the established interventions and the various reports that are based on applied behavior analysis, there are a number of established interventions, antecedent packages, behavioral packages, comprehensive behavioral treatment for young children, joint attention interventions, modelling, of course, natural environment strategies. They are very important these days, where you really just use the natural environment and find the teachable moments. Peer training, pivotal response training, I've already mentioned that, schedules, self-management, and of course story-based intervention packages. These are all evidence-based, and these are all assessed in various reports to ensure that they are becoming available. Another really important point for measuring is the social validity measures. Social validity is the social importance and the clinical acceptability of the treatment goals, of the procedures and the outcomes. So you have three aspects and two criteria for each of the aspects. So you have the social importance of the treatment goals and the clinical acceptability of treatment goals, the social importance of procedures and the clinical acceptability of procedures. And again, the social importance of the outcomes and the clinical acceptability of the outcomes. And when you ask the parents of the young children with autism, over 70% would rate the social validity of ABA-based interventions very highly. And they would also state that they have reduced stress levels. The cost-benefit analysis is also very clear. The lifetime cost per person is in around between 1 million and £1.5 million. The annual cost to the UK is 32 billion, and the cost for ABA-based interventions, when it is used as shadow education, which basically means when it is not funded through the normal educational procedures, it can be 20 to 40,000 pounds for 2 or 3 years, definitely. This seems to be quite expensive. But the issue is here that if it was used consistently around the school, throughout the school system, there would be no need, because if behaviour analysts were freely available in the statutory health, social care and education system, they already employ a lot of staff. They employ teaching assistants. If those teaching assistants were trained in ABA and they were able to conduct ABA-based interventions, there wouldn't be any extra cost. Maybe a supervisor, but that could be a teacher who's trained as a behaviour analyst. Not just through a couple of hours or a couple of day courses, but actually through a master's degree in ABA and applied practice, supervised practice time. And as you know, the masters in ABA we offer the Queen's, and there are other courses as well. So when we're doing this, we can reap the fruits of our labours. The ABA-based interventions in America are now considered treatment as usual. And the cost in America is 26 cents per member per month. This is when the Americans are paying for the insurance, they would have to pay 15p more per member per month in order to get all of this applied. The effect is the optimal outcomes, highly statistically significant link between optimal outcomes and ABA-based interventions. So, not surprisingly, therefore, in America, the ABA is very well supported and very well endorsed through the Surgeon General from quite a long time ago, it's now over 50 years ago, and from the Office of Personnel Management, the Benefits Review Panel, and of course also from the American Academy of Pediatrics publicly endorses ABA-based treatments. And finally, I want you to watch the video that you can see here, the URL. I want you to watch that video for that is Laurie Unum, who brought the laws to ensure that ABA-based interventions are funded in America. She is the key to that work, and she was at Queen's in 2013 giving a talk, so feel free to have a look at that talk.